I'll start recording. Okay, so basically when we're talking about, all right, the machinery of the heart, this first, we talked, like I was saying, we talked about the conduction system, and that's what we're seeing here, okay? And we're basically seeing, all right, the SA node, all right, that's where you're going to see those nodal cells, all right? Remember we talked about that characteristic that they have, that spontaneous depolarization, or what we call the autorhythmicity, right, where these cells don't need to be stimulated to depolarize, okay? They just do it on their own, okay? So they'll start to depolarize, all right, and then that will cause, all right, that depolarization of the cardiac cells. Okay, remember, there is that, what always follows depolarization? I know it's a tough one. Contraction, okay? Cell will depolarize, all right? And then that will trigger contraction by cardiac muscle cells. So keep that in mind, all right? Contraction is always going to follow depolarization. Now in there, obviously, if you have depolarization, you're going to have repolarization, okay? It's like what goes up must come down kind of thing, okay? So you're going to have that going on. We're going to get into some of that in a moment here, okay? So we're seeing, right, the SA node, our pacemaker, okay, we're seeing that depolarize. It's going to spread out like a wave, right, across the atrial walls. And that will cause then pretty much both the atria to contract, all right, in unison, okay? So as we get down here, our signal starts to depolarize across the atria. Then we get to the AV node. Remember, the AV node is like our bottleneck. That's where our conduction system slows down for a moment, which is good. We want that. We need that because, one, we got to give the ventricles that last little bit of blood, okay? Because remember, it's the atria, all right, contract, and they're going to squirt a little bit of blood, all right, into the ventricles, okay? And at that point, the amount of blood that's sitting there in the ventricles, all right, we call that the end diastolic volume. You need to know that, all right? So following the atrial contraction, that blood gets squirted into the ventricles, okay? And we're done with the filling of the ventricles, right? And that volume of blood in the ventricles at that point is the EDV, end diastolic volume. All right, so while that's going on here, all right, the AV node, all right, is going to kind of slow down our conduction system, signal for a moment, right? And it does that because, one, all right, the signal, all right, our conduction can only go in this pathway. All right, they call it the skeleton of the heart, not like a bony skeleton, all right, but it's a fibrous tissue skeleton, pretty much forces, all right, the depolarization signal in this direction towards this structure here, okay? So, and we have fewer gap junctions. Remember, gap junctions allow ions to flow across the cells. It's the path of least resistance, but that also promotes, all right, that depolarization, okay? So now the AV node slows it down for a moment, but then it depolarizes, okay? And then it's going to start to send its action potential down here, all right, through the AV bundle, all right? So we'll see that here. Come on. Come on. Okay? So that's what we see here. Our action potential starts to transmit down the AV bundle, and it splits off into the right and left bundle branches. Then eventually that's going to go into the Purkinje fibers there. The Purkinje fibers are the remaining fibers of the conduction system that are found in the ventricular walls and the intraventricular septum. Okay? So they'll be located here. So then by the time we get to, all right, the Purkinje fibers, they'll start to trigger that depolarization, but it starts down here in the apex, and it spreads upwards. Okay? So that's why on that one video we saw, the heart, when it was contracting, the ventricles contract from the top down, and the atrium, did I say that? Flip that. The atria contract from the top down, and the ventricles contract from the bottom up, which makes sense, right? Atria contract from the top down to push the blood into the ventricles. Then when the ventricles contract, they contract from the apex of the heart and push it upwards and out through the semilunar valves, into the aorta and into the pulmonary trunk, okay? So that's what we're going to see. And I can play that video again. Has anyone watched that video since I showed it? No? All right. No, you got a test. I get it. And you had the Super Bowl. All right. We'll not hold that against you, but watch that video. It's 4 minutes and 11 seconds. You watch that a couple times. You can figure it all out. It'll help you. Okay. So pull it back from here. All right, so that's basically what this slide here is going to tell you, all right, in words, what I just showed you in the pictures there, okay? So when we're dealing here with that contraction, all right, especially with when the Purkinje fibers are causing that depolarization, we speed up that conduction system signal there because, hey, remember, the larger the diameter of a nerve, the quicker an action potential will travel through that. All right, remember there's two things that affected the speed of an action potential. This is back in chapter 12. The diameter of the neuron and if it's myelinated or unmyelinated. We're not dealing with the myelination here, okay? But we are dealing with the diameter, okay? So that's why we see in this area here, the Purkinje fibers, a rapid discharge here. And that allows, and we need that because we want to make sure that the ventricles contract at the same time. If they're not contracting at the same time, we're going to get into some problems, and I'll talk about that. All right? It can damage the heart. It can cause turbulent blood flow. And anytime you get turbulent blood flow, you get a chance of clotting. And we can't have that. We can't be throwing blood clots off in the heart. All right? It's supposed to be pumping the blood out. It's not supposed to be clotting the blood. Okay? We already know the roles of the papillary muscles. Those are the anchors. Remember I used that parachute, all right, comparison on Wednesday? Yeah, Wednesday. So those papillary muscles, as the ventricles are contracting, are going to pull down on the chorda tendineae, and they're going to help pull the AV valves shut or hold them shut, okay, as the pressure is building up inside the ventricles. We don't want backflow of the blood. Blood is supposed to go in one direction, in and out of the heart. Right? The valves, their job is to prevent backflow. They ensure that the blood is moving in one direction here, okay? So again, keep that in mind. We stimulate those Purkinje fibers at the apex of the heart. So that's where it begins, and it starts to contract and depolarize, then it contracts. It pushes that blood upwards and out of the heart. All right, that was the review. Okay, so now let's talk about the new stuff. Okay, so let's talk about the workhorse of the heart. All right, we saw the nodal cells, and they're going to be part of that contraction system there, or excuse me, conduction system. Now the workhorse are the cardiac cells. We've seen this. So let's talk about some of the parts to our machinery here. All right, we're all familiar with all of this. Sodium, potassium ion pumps, calcium pumps, and then our leak channels. Okay, their job, all of that, that part of the cell is meant to maintain the electrochemical, oh, that's awful. Hold on, I apologize here. Why am I doing that? Why do I make my life hard? Gradient. Okay, the electrochemical gradient. Remember that term from the neurons? All right, the flow of ions across the plasma membrane and the movement of those ions, all right, which establish this. All of that to establish our resting membrane potential of -90. You need to know that value. Okay, so all of those machinery parts up there, the pumps, channels, establish that electrochemical gradient, which gives us our RPM, or the resting membrane potential, of -90. Okay? So when we were talking about the nodal cells, we saw these ingredients here, these three channels, except in nodal cells, it's a slow voltage gated sodium channel and a fast voltage gated calcium channel. In the cardiac muscle cells, it's a fast voltage gated sodium channel. Okay, so we just flip-flop them. All right, so in this situation, all right, we're dealing with fast voltage gated, slow voltage gated calcium channels, but then we have our regular potassium, voltage gated potassium channels. That doesn't change. Okay. So, of course, when the cell is at rest, just like when we were talking about the resting membrane potential of a neuron, all right, all of the voltage-gated channels are closed. That's what we're going to see here. We're going to start off with the cardiac muscle cell resting. Depolarization, followed by repolarization for the electrical part. That depolarization triggers contraction, followed by relaxation. Okay, so we just caused the muscle cell to relax. It's at rest now. So all the voltage-gated channels are closed. All right. So here's a quick picture of our channels here. Here's our cardiac muscle cell. And then you can see, all right, our cell is at rest, so all of these channels here are closed. All right, and so there's no flow of ions through these channels because they're closed. But the sodium-potassium ion pump is working all the time. The calcium ion pump is working, and leak channels are always open. So stuff is still going to flow across the plasma membrane. All right, but these voltage-gated channels are closed. Okay, so that's what gives us, here's our resting membrane potential, -90. Okay, so let's tell the story. All right, let's tell the story of what happens, okay, during contraction. All right, but we're going to start off with this, depolarization. Here are the electrical events, and you should kind of know this already. We're going to get depolarization followed by repolarization, but we have a special phenomenon that occurs, and we call that the plateau, and I'll talk about that. But the plateau is hugely important, and I'll talk about that in a moment here. Okay, so first, depolarization. We know what that is. Okay, the nodal cells are going to depolarize and then cause the cardiac muscle cells to depolarize. Right, so our conduction system is going to kick in, or the gap junctions. The gap junctions allow for the flow of ions between cells. Right, so what's the first thing that happens? All right, we're going to start off with the sodium ion channel. Okay, so the fast voltage-gated sodium ion channels open up first. So that causes a huge rush of our ions of sodium from outside the cell to enter the inside of the cell. Okay, and it's so much of a rush that our resting membrane potential goes from a -90 all the way up to a +30. With the nodal cells, all right, they only went to 0. And then those slow voltage-gated sodium channels close down. Well, here, our fast voltage-gated sodium channels open up, and sodium rushes in so much it shoots past 0, and it goes to +30. Okay? So once we hit that value, then those channels will inactivate or close. All right? So I'll show you right here real fast. That's what we see here on our picture here, all right, of the electrical event. Right? -90 millivolts, right? Sodium, the fast sodium voltage-gated channels open up, and look at that. Boom, it takes off, shoots right up in virtually no time whatsoever. All right, bam, goes to that +30. They shut down, they close down. Okay, now, and that's what we'll see here. I'll actually take you through three slides here. That's what we're seeing right here. Okay, here's our fast voltage-gated sodium channel. It opens up, sodium floods in. We go from -90 millivolts resting membrane potential to +30. Good so far? All right, so yeah. The picture, this guy? And that's what we're seeing here, all right? For that depolarization, sodium flows in, and it shoots the membrane potential to that +30 value, okay? So that's the first part. There's 3 parts to this, okay? There's 3 steps or phases, all right? The second is what we call the plateau. The cell is still depolarized at this point. The fast voltage-gated sodium channels are closed now. That triggers the opening of the slow voltage-gated calcium channels, and also triggers the opening of the potassium channels. So remember, potassium is in higher concentration inside the cell, so it wants to leave. Okay, so it leaves when those potassium gated channels open up. But calcium is in larger concentration outside the cell. So when its slow voltage-gated channels open up, calcium is going to come in. So they're almost exchanging. I'm going the wrong way. It's almost exchanging. Okay, so you have a positive ion leaving the cell because potassium is a positive ion, but you also have a positive ion coming in. That's why I'm going to come back to this slide. That's why you see this plateauing going on. Okay, this plateauing goes on because potassium left initially. All right, but then calcium, those calcium channels opened up, and calcium's entering the cell. So we have an outflow of potassium and an inflow of calcium, but they're both positive ions, so we're not going to see too much of a change here. All right, so that's why it kind of levels out for a moment. And then when the calcium, the slow voltage gated calcium channels close, then we get into that repolarization. It drops off because now there's no more calcium coming into the cell, and only potassium is leaving the cell and taking its positive charge with it. So it's making, all right, the inside of the cell more negative, and that's what we're seeing here. So here's the plateau phase. Okay, so our fast voltage gated sodium channel is now closed, and we get our slow voltage gated calcium channel. It's opened up, so calcium enters into the cell. But meanwhile, our voltage gated potassium channel has opened up also, and potassium's leaving. So it's almost just like an exchange there. All right, so you have positive ions just flowing in and out of the cell. Okay, so that's why it kind of levels off there. But then eventually this, all right, channel will close. And when that happens, all right, we no longer have a positive ion entering into the cell, but we have one leaving the cell. So as that positive ion is leaving the inside of the cell, it's taking its positive charge with it, making the inside of the cell more negative. Hence, that's the definition of repolarization. Depolarization is making the inside of the cell more positive, right? And repolarization is making the inside of the cell more negative. Okay, so that's what we're seeing here. Going back to this slide. There you go. Plateau phase. Okay, so that's what we're going to see. Now, that's one of the ways that we're going to get that calcium into the cell. All right, so as that occurs, all right, this phenomenon is going to trigger the sarcoplasmic reticulum, because remember, what's our sarcoplasmic reticulum? It's our storage reservoir for calcium. And we need calcium. Do you folks remember why we need calcium? For muscle contraction. Remember chapter 10, what it does? It triggers the removal of the regulating proteins. Remember troponin and tropomyosin? It sits on top of that troponin, and it triggers troponin to move the tropomyosin off of the actin binding sites. So now we can get that cross bridge formation. So the more calcium that we can get into the cell, right, the more cross bridges that we can form. And we're going to hit on that concept here soon. So keep that in mind. The more calcium we have, right, the more cross bridge formations we can have, which means we can get stronger, more powerful contractions. Okay, keep that in mind. All right, but understand that in the plateau phase here, we are still depolarized. Okay, you might see a test question on that. All right, and our final phase here, or event, is repolarization. So eventually the voltage-gated, or the slow voltage-gated calcium channels will close, but at the same time, those potassium channels remain open. Right? And then we're going to return our membrane potential back to that negative 90 value. Okay, that is our resting membrane potential, negative 90. And then the cell can depolarize again and contract. Okay, those are the three events. That's why, all right, we see here on this graph here. So you should know, when you see this graph here, we're talking about a cardiac muscle cell. If you see, whoops, if you see this one, whoops, this graph here is a nodal cell, right? So when it looks like, when we're talking about depolarization of a nodal cell, right? Two different looking graphs here, right? This is the nodal cell as it's depolarizing, okay? And then here is the cardiac cell as it's depolarizing. That's what it looks like. Okay, so you should be able to see that once, because this is pretty unique, this appearance here. Okay, and we're going to talk about the significance of the plateauing here in a moment. All right, did everyone get that part? The repolarization? Okay. All right, so to just recap the importance of calcium, all right, calcium can enter into a cardiac muscle cell through two methods. It can be released from the sarcoplasmic reticulum, or it can come from the interstitial fluid, which is the fluid that surrounds the cell. Right? Now, when we were learning about the skeletal muscle, we kept talking about calcium coming from the sarcoplasmic reticulum. All right, we didn't talk about calcium coming into the cardiac muscle cell, excuse me, the skeletal muscle cell from the interstitial fluid, right? Because there are no voltage-gated calcium channels, right, on the sarcolemma of a skeletal cell, okay? So keep in mind, same series of events. Calcium gets released into the cell either through the interstitial fluid from the calcium gates, all right, the voltage-gated calcium channels, or through the sarcoplasmic reticulum. Regardless, it gets into the cell. What happens? It binds to the troponin, tropomyosin complex, right, and it opens up those binding sites for us to make our cross bridges. I will not go through. You guys should all know this already. This is from last semester in 210, right? How cross bridge occurs, power stroke, right? That whole thing. Okay. So what will happen then, following the contraction, okay? Once we see a decrease in calcium levels inside the cell, we'll start to relax the cell. How does that happen? Calcium pumps. The calcium ion pumps, which are located in the sarcoplasmic reticulum and in the sarcolemma, will pump calcium out of the cell and also it will pump calcium into the sarcoplasmic reticulum. Okay? So if we want to decrease contraction, we got to get rid of the calcium. If we want to increase contraction, we need to have an abundance of calcium. So at this point, we should be thinking calcium's the key. We need calcium, all right, to get, this is the important, that's why you should be drinking your milk, all right? I'm just kidding. Actually, there's more calcium in a cup of broccoli than there is in a cup of milk. Fact. Fact. So eat your green leafy vegetables and your veggies, okay? That's my PSA for today. All right, so that's what you're going to see, right? High calcium levels, then we can have contractions, and a lot of it. Low calcium levels, that's a problem, okay? Because we need that calcium to remove those regulatory proteins there. Okay, this I love. Has anybody known anyone in their life or ever heard of somebody having tetany occur in their heart? You know what tetany is, right? It's a sustained contraction, all right? So we learned a little bit about it when we were talking about the skeletal muscle. I'll come right back to this. Well, no, let me stay back on this slide here. All right, I know you guys are copying stuff down and I'll talk. All right, so let's jump back to skeletal muscle, okay? One action potential will initiate usually a contraction or one stimulation there. But we learned briefly what happens if you keep stimulating that muscle. All right, you'll get a sustained contraction if you do it enough times, okay? So think of it like if I zap the muscle with some electricity, it'll jump, it'll contract, okay? Now what happens if I do it a couple more times, but really close together? It'll jump faster. But if I keep doing it, I'll have a sustained contraction. It'll just sustain that contraction. You think that's bad for the heart? Darn right. If your heart had the potential to be in tetany, because that's the whole purpose of the heart. It's a pump. It needs to contract and relax, because it needs to fill up. You'd be dead. So here's the beauty of how the heart was designed, and I think it's so cool, all right? The heart cells, the cardiac muscle cell, has a long or sustained refractory period, which means, and if you remember from 210, all right, when we studied the skeletal, when we studied muscles, all right, the refractory period is a period of time following a contraction in which when you stimulate the cell, it will not contract, okay? And there's, with the skeletal muscle cell, there's two types. There's the absolute refractory period, no matter how many times or how powerful the stimulus is, you cannot cause, all right, that muscle to, or you can't activate that nerve. It has an absolute refractory period, okay? And then you have the relative refractory period, which is if you stimulate enough, you can actually get it to contract, all right? In this situation, when we're talking about the cardiac muscle, all right, we cannot fire a new impulse during our refractory period. You need to know this time. It's 250 milliseconds, about a quarter of a second, okay? So that means we cannot get that muscle cell to contract no matter what we do. We can keep zapping it with action potentials, but we have to wait this period of time. And that has to do with the plateau phase. So that this phase here, this right here, is responsible for that. Why? Because potassium is flowing out of the cell, calcium is pouring into the cell. All right, that phenomena right there prevents this muscle cell from contracting, which is good. So now we never have to worry about the heart going into tetany. Well, that's one less worry that we have. All right, we won't have the heart have that sustained contraction there. Okay, so that allows us the love dub. All right, the contraction and relaxation. Contraction is systole, relaxation is diastole. So we get that contraction followed by relaxation. And then when it gets stimulated again, contraction, relaxation. Okay? So you definitely need to know, all right, that the reason why, all right, the cardiac cell cannot go into tetany is because of that plateau phase. Okay? Pretty cool. It's like a built-in system to allow the heart to never go into tetany. Because that you'd be dead. You would be dead. Okay? So this is what we saw when we were talking about the skeletal muscles. Right? So here, this first blue spike here, that's our depolarization, followed immediately by the repolarization. And then you have the refractory period here. That's tough to see. All right, so our refractory period is tiny for the skeletal muscle cell, and that's only after one stimulation there, one single stimulation. All right, then it's followed by muscle contraction and then muscle relaxation. That's what we see. Depolarization comes before the contraction. So now what happens? Let's start to stimulate that muscle with a lot of stimulation, and we're going to increase the frequency. All right, so we zap it, wait a second, zap it again. All right, wait a second. Now we're going to zap it twice in that time. So we zap it, we start to get, all right, contraction, relaxation slightly, but when we keep doing it and we hit that certain point of just stimulating that muscle cell, then it just goes into a sustained contraction. All right, and it doesn't have any relaxation until that muscle reaches fatigue. What causes it to reach fatigue? Runs out of ATP or runs out of calcium. Okay, because then it can't contract. So we don't have to worry about that when we're dealing here with our cardiac muscle cells. Okay, so you can see here, here's the cardiac muscle cell, right? Depolarization, followed by that plateau phase, and then our repolarization. But look how long that refractory period is. So during that refractory period, we've caused the muscle to contract, and it's also going to relax for part of that time. All right, that's a long time. Right, so we'll see here. All right, we've now stimulated the heart cell twice, once here and once here, but we could not get a contraction until 250 milliseconds later, because we need, all right, the calcium to enter into the cell, and then it gets pumped back out. All that process that we've already learned about what happens. All right, for that depolarization followed by repolarization. So we just have that long refractory period. So has anyone here ever had an ECG done on them, echocardiogram? No? Where they put the leads on you? Yeah. You know, and you'll see it in TV shows. You'll see that thing going beep, beep, you know, and, oh, they're flatlining, that kind of thing. Well, that's watching. There's a bunch of other things I was watching, but the electrocardiogram is basically a tool that we use to monitor the conduction system and see how well. After a certain age, I hate to say it, but I'm in that age category where every time I go for a physical, I have to get one now, even though I don't have any known heart problems. All right. So I'm going to teach you a little bit about it. We're going to talk about it. All right. Because I'm telling you what, ECGs are, they're tough if you don't know what you're looking for. I'm just going to teach you the basics. All right. So basically what we do is we put these electrodes on you. All right. And there's different ones. And in fact, I think with some of these Apple Watches, they can actually monitor, the newer ones, they can monitor your conduction system. They can do kind of like a mini ECG. It's not going to be too detailed. The best way to do it is to go in and do, I think it's a 12 lead is the one where they go in and they put all these little skin electrodes on your chest and on your arms and legs. And then what they are able to do is they're able to monitor the electrical signals from your cardiac cells, the muscle cells there. Okay, very helpful, very, very helpful tool for diagnosing several types of issues that are happening. Okay, so let's talk about what this tool is. First of all, right, there are a couple different parts to the ECG. There's waves, segments, right, and intervals. So we're going to talk about the waves and the segments first. Okay, so the P wave, that's this first little blip that you'll see. All right, the P wave, and you need to know this, this is when the atria are depolarizing. Okay, so that all starts with the SA node, right? Isn't that where this whole thing starts? Okay, so what follows depolarization? Right, contraction for the actual muscle part, but also repolarization too. So we're going to see also on our ECG, we'll see a repolarization for the atria. Well, actually, we won't see it, and I'll tell you that in a moment why.
So
all right, go ahead.
Depolarization, does contraction and repolarization happen at the same time?
It can. It depends on what cell that you're talking about. But for the actual phenomena, depolarization is going to be immediately followed by repolarization, and a lot of times contraction will occur during that repolarization process. But I always want you to think, when a cell depolarizes, right, if we're talking about a muscle cell, it's going to contract. Okay? So following the P wave, all right, we've got this thing called the QRS complex, and it looks like this. It's big, that big kind of blip that you'll see. Okay, that's this big thing right here. I drew that wrong. That should be straight. All right, here's our P wave. All right, and then we get that big shooting up wave, and then it dips down like that. Okay. So this, all this right here, that's the QRS complex. Okay, and that has to do with the ventricles depolarizing. Okay. Now, during this QRS complex, the atria will repolarize, but we can't see it in here because when the ventricles are, it's such a big phenomena, all right, as they're depolarizing, all right, we lose the atrial repolarization. Okay, so we can't see it. It's buried somewhere in here. We just know it happens in here. Okay. And then obviously following the QRS complex, this next little bump right here, that's the T wave. Okay, and that's our ventricle repolarization. Okay, so this is the P wave, this is the QRS complex, and here's the T wave. Right there. I'll do you one better. I'll show you here. That's way better. Okay, so you can see. Okay, P wave, here's the QRS complex, right, all here, and then our T wave. Okay, so this is the atria depolarizing. This is the ventricles depolarizing. And this is the ventricles repolarizing. Right? Atria repolarization occurs somewhere in here, but we just can't see it. Okay? On this electrocardiogram, the ECG. Okay? Get back up. Did you guys get that? Okay? So that's what we're seeing. Depolarization, repolarization. So that's for the waves. Okay, so that's the first part. Let's talk about the segments now. We're going to talk about, all right, the PQ segment, and then we're going to talk about the ST segment. Then there's one more thing that we'll talk about after that. Okay? So first of all, when we talk about segments, all right, I want you to think of contractions. All right? So keep that in mind. These segments are going to occur where? Plateau phases. Remember the plateau phases, all right? So we're not going to see any change, all right, for the most part in the electrical current or charge there. Okay, so it'll be a flat line. So I'm going to come right back to this slide. So right here, this is the flat portion here. That's no change. So we obviously, when you see a bump there or a dip, there's a change in the electrical charge. But when it's on this horizon here, all right, that's no change. So you'll see with the PQ segment and the ST segment, that's going to be on this flat portion here. Okay, so there's no change in charge. Right? No repolarization, no depolarization. Okay, but you're going to see contractions. So what contracts first? in the heart cycle? Which part of the heart contracts first? Out of the 4 chambers, which 2 chambers contract first? Yeah, the atria, the top 2. So I don't even have to put the slide up here. So this PQ segment is going to be representing atrial contraction. Okay? The ST segment is going to be ventricular contraction. Okay? That's what we're going to see. And that makes sense because guess what? The P wave is depolarization of the atria, followed by the contraction, which is followed by the PQ segment. Okay? See, I told you, you guys are going to be able to figure this out. You'll be geniuses. You go see your doctor, they do the ECG, and you, oh yeah, I know what that is. P wave, QRS complex, ventricular depolarization. They're like, dang. No, you had Dr. Kotz. All right, so that's what you're going to see here. This is important. So the PQ segment is going to have to do with the atrial cells. The ST segment has to do with the ventricular cells. All right, they both have to do with the plateaus. All right, so they both involve contraction. Okay, we're good with that? You feel pretty confident in that? Not too bad, not too bad. I won't be asking you to look at ECGs and be able to tell me if somebody has a 1st-degree heart block or 3rd-degree. You don't have to worry about all that stuff. Okay? All right, so remember.
We just need to think contractions for everything.
Depolarization, repolarization, and contractions. That's really what you need to be concerning yourself with. If you see a bump, all right, it's going to be depolarization. All right? Well, not all the time. I should forget I said that. I did not say that. All right. So the last part is going to be these guys here, the intervals. I'm going to come right back to this slide here. I just want to show you. All right. So P wave, atrial depolarization, QRS complex, ventricular depolarization. The T wave is going to be ventricular repolarization. We will not see the atrial repolarization on our ECG. The segments here, okay, these areas here have to do with, all right, the cells contracting. The first one, the PQ, follows the P wave. That has to do with atrial contraction, right, but the plateau phase. Right? ST segment follows the QRS, which means that the QRS represents ventricular depolarization. This segment represents ventricular contraction, specifically the plateau phase. Okay? So now we're going to talk about the intervals. Okay? So the interval is going to cover, all right, well, let's go in here. All right? So our first interval is the PR interval. Okay? And that has to do with, all right, so we see, I'm going to come right back. Our PR interval starts with the beginning of atrial depolarization, right? And it leads all the way up to the beginning of the ventricular depolarization. So what can we infer from here, right? Atrial depolarization and the beginning of our ventricular depolarization. Basically, the information that we get from the PR interval is how much time it takes for an action potential to travel through the entire conduction system. So if we see a prolonged PR interval, then we're going to say, why is it taking a longer time for our action potential to get through the conducting system? There could be a problem with some of the neurons. Maybe something's going on at the AV node. Maybe there's something going on at the bundle branch. Or the Purkinje fiber. Something's happening. So if we see a prolonged PR interval, then we're thinking, okay, something's up with the conduction system. All right, the QT interval, right? Can come right back. Here's the QT interval, right? It starts at the beginning of the QRS complex, right? It goes all the way to the end of our T wave. So that's going to include, right, ventricular depolarization all the way to ventricular repolarization. So that's what we're going to see with the QT interval.
It's kind of weird how they set it up.
Yeah, oh, absolutely. But what we learned from the QT interval is how long it takes, all right, for the ventricular action potentials, all right, to pass through the ventricles. Okay, so now if we see that there's a longer period of time in that interval, then we say, okay, what's going on? Scar tissue, perfect example. That person could have had an MI, myocardial infarction, in which it won't move through the cardiac tissue as well. So we could see that. All right. So again, this, what we can confer from the QT interval here is heart rate. Heart rate. If you have a slower heart rate, you'll have a longer QT interval. If you have a faster heart rate or tachycardia, all right, we'll see a shorter QT interval. Okay, so there's, again, these different parts give us plenty of information, and there's way more. I mean, when I took ECGs in med school, I think we spent 4 months just going through all the different possibility of different pathologies and trying to read it off an ECG. Interesting stuff. Okay, so here's what we're going to see. Now we're going to overlap our cardiac muscle cell onto our ECG here. Okay, so what this is showing us here is for the atria. Okay, as the atria depolarize, right, we're going to see that contraction or that depolarization of the atria, and that's where it fits in on our electrocardiogram. And then you can see that same type of configuration here, right, for the electrical system for the ventricles.
You can see that on the machine?
No, you won't see this.
Oh, that's it.
I know. No. But this is what you should be thinking. All right, what phenomena is occurring here? So you know at the top here, all right, of your P wave, you know, okay, the fast voltage gated sodium channels have opened up, all right, and sodium is flowing into the cell, right? And then as the P wave starts to dip down, then we're seeing, all right, right here during our plateau phase, right now we're seeing contraction occurring, right, the contraction of the muscle, but we know calcium's entering into the cell, which is good, right, because we need calcium for contraction, calcium good, all right, but potassium is leaving.
The contraction, you know that the calcium is going into the cell.
Exactly.
If it doesn't contract, then that would mean that they might not be going.
That's one of the causes. Yeah, if you see poor contractility, you can assume there's a variety of reasons. But if you look at their blood panel and you look at, oh, they're hypocalcemic, they have low blood calcium levels. Okay, that could be what's causing this irregular ECG. Yeah, I mean, it's a useful diagnostic tool. I find it's very, very helpful. But just to kind of superimposing so you can kind of see what physiological events are occurring in our electrocardiogram here. Which leads me to arrhythmias, right? Irregular heartbeats, right? So when we're talking about the electrical activity of the heart, we have to talk about arrhythmias here. And we have what we call our heart block. And this is what the example that I was using earlier, all right, when I was talking about that PR interval. If we see a prolonged PR interval, then we can assume that there's some sort of heart block going on, right? So these first two, look at these symptoms here, and I always draw into folks here. Lightheadedness and fainting. People don't realize, especially, and even when you are short of breath at times, okay? Especially if you're a younger person, the cardiac system gets overlooked quite frequently in regards to that. It's always somewhat considered, but it doesn't get its just due. But when we're talking about heart blocks here and causing the pathology or the irregular functioning of the contractility of the heart, some of the symptoms that we see here, lightheadedness, fainting in significant cases, telling me, okay, well, if I'm fainting or getting lightheaded, that means oxygen is not getting to the tissues of the body. So what gets the oxygen there? The heart, the cardiovascular system, right? Irregular heartbeats, you can have, all right, we'll see it on an ECG, we'll see some of that. But chest pain, of course, that's usually one of the symptoms that people think, all right, the heart's definitely causing that, or there's a lung issue going on. But usually when people get these palpitations, that fluttering of the heart, right, and in some cases chest pain, they're going to head right towards there's a cardiovascular issue happening here. So we break down these heart blocks into 3 degrees. The first one is the most mild, and the third one is the most severe. Okay. So the A-B block, the first degree, is basically we've just slowed down the conduction system somehow. Something's going on in which that active potential is not traveling through, all right, for whatever reason. Okay, you can have some electrolyte imbalance going on, for example, could be one of those reasons. All right, dehydration is a primary cause for that. Okay, but what we're seeing is we're still getting that active potential traveling through the conduction system. It's just not going as fast. Okay, so not a huge deal, but something that needs to be considered. All right, second degree heart block. All right, now we're seeing failure of some. All right, now not all, but some of those active potentials are not making it into the ventricles. Well, that's going to start to become a problem because the ventricles pump that blood out to, one, the lungs to get oxygenated, and two, your body. Okay, so that's where you start to see a lot of these symptoms up here. Okay, and then finally, the last one here, all right, third degree is when we are not getting any action potentials going to the ventricles. Okay, that's a big problem, obviously. That could lead to death, all right, severe compromising of tissues because we're not pumping the blood out there. All right, so the third degree block is complete. All right, and there's several causes for that. Perfect example, I mean, if you just sever, all right, the interventricular wall there, and you cut, that's where those fibers come down, go out to the Purkinje fibers. If you get cut there or whatever, right, that can cause a third degree block. Scar tissue, MI, myocardial infarction, primary cause, okay? All right, so that's for the third degree. All right, has anyone ever had PVCs, premature ventricular contractions? I bet you some of you had if you've ever drank too much caffeine. Yeah, it's happened to me. It was interesting. I was an addict, excuse me, to Mountain Dew when I was in med school. I didn't drink coffee then. I didn't like it, I know. Now I drink coffee all the time. So I used to drink close to about 2 liters a day, which is awful. It's awful. But I needed the sugar, stay awake from the caffeine. Well, in one of my classes, we had to do, in physiology lab, we actually got to do a 12-lead ECG, and they put me on it, and sure enough, I had premature ventricular contractions. So we'll see a lot when we get stimulants, nicotine, all right, caffeine, all right. Check this out, stress, sleep deprivation. I think that includes every single one of us in here. So at one point, we've had, I'm sure we've all had, possibly, premature ventricular contractions. All right, so basically that's what, when we get these premature ventricular contractions, right, something is up with those action potentials, okay, and it usually has to do with the AV node, all right, or the conduction system in the ventricles there, all right. Most of the time you won't even know if you're having one, okay, you just don't, depending on what the cause is, okay. Fibrillation, atrial and ventricular fibrillation. That is when it's almost like a fluttering of the heart. Now, obviously, if you have to have one, you want to have the atrial. Because what do the atria do? They help fill the ventricles. Okay? So you'll have an issue, all right, with filling of the ventricles. Okay? So end diastolic volume might be impaired, right? But that has to do with the atrial action potentials. Ventricular fibrillation is a different story, and I mentioned this earlier. If we're having an issue here, all right, with the action potentials in the ventricles and causing the ventricles to malfunction, then we're having a problem because now it's crucial that your ventricles contract at the same time. If they're off, if they're out of sync, then that is going to cause problems later on because you have to understand, all right, whatever the left ventricle pumps out to the body, right, it's eventually going to come back into the right atrium. Okay, so we're going to talk about cardiac output here and then venous return, and which is pretty much the amount of blood leaving the heart is going to be equal to the amount of blood coming into the heart. Well, if these ventricles start malfunctioning and pumping out of sync and causing issues with that, that's going to kind of mess up our system, right? And if it gets bad enough, it can lead to death. We can start killing our heart cells, and we don't want that, right? So how do we get things back in order? Shock them. Use a defibrillator on them or install one. All right, there's been plenty of times where folks have had their irregular heartbeat corrected. I've talked to plenty of my patients. They've gone in and they have the doctors shock them, and it puts them back into sync. So you'd be surprised. And most of the time, your body will self-correct it. It's happened, okay? Because the conduction system's not perfect every single time it discharges, right? Most cases, it may go unnoticed, depending on how bad that fibrillation is. But in some cases, if it gets bad enough, right, one of the treatments is we'll put you on certain drugs that will help manage that. Or you might just need a one-time shocking, all right? You just go into the hospital, we zap you. All right, you're good. See you later. Take care. Have a good one, okay? You guys remember this, the cardiac cycle? All right, quick review. I'm going to run through this just real quick because I just want to hit some of these high points just to make sure, all right? So basically, the cardiac cycle has to do from one period of contraction followed by a period of relaxation, the lub-dub, okay? So that's what we're going to talk about. So, quick review. Contraction is known as systole. All right, relaxation is known as diastole. Good with that? Okay, so when you're looking at your blood pressure readings, that top number is systole. That's the amount of pressure when the heart's contracting. The bottom number is diastole. That's the amount of pressure that we see in your blood vessels when the heart's relaxed. Okay, so this is important. Contraction increases pressure. Relaxation decreases it. Do you feel pretty comfortable with that? Yeah, I hope so. Okay. I look at it like this. Just puff your cheeks out, keep your mouth closed. All right, as you puff your cheek out, you're increasing the pressure, you're contracting your muscles there. Okay, so follow that concept then, and keep in mind, blood is going to move down its concentration, or excuse me, its pressure gradient. Okay, so it's going to go from an area of high pressure to low pressure. All right, and that's what happens when you're contracting. You're building up the pressure in that chamber, and it's going to push blood out of that chamber to an area where there's less pressure, be it from the atria into the ventricles or the ventricles into the arterial bloodstream. Okay? That concept there. And then, of course, I mentioned it earlier in today's class, our valves, they have one job to do, and that is to prevent backflow. Always make sure the blood moves forward, ever forward. Okay? That's their job. No backflow. All right? Get blood into the heart and out of the heart. Doesn't go backwards. Okay. So, if anything, you should know this slide very well before you proceed in trying to learn the rest of the cardiac cycle. Just know these points here. This is very important that you understand that. Okay? All right? I like the fast-talking video guy. Wait, who? Is that me? Which guy are you talking about? What is that called? There's a YouTube channel series. If that's the one I'm thinking of, Tiffany. The one who speeds through. Oh, okay. Do you, I think is that Crash Course? Oh, some blonde guy. Is that really his name? Blonde guy? No. Check out Crash Course too. Okay, gotcha. Blonde guy is really his name. So if I Google him, I will find his YouTube page. I should change my name to Red Guy. All right, let's. No, not Crash Course. I gotcha. Okay, that's another good one though. I like Crash Course. All right. So when we talk about the cardiac cycle, we are focusing on ventricular activity. Right? We don't talk about the atria all that much because the atria do one thing. They contract, and then the rest of the time, they're relaxing. So we don't really pay much attention to them. It's always going to be focusing on the ventricles. Right? So easy to remember. When you have contraction, you increase pressure. When you have relaxation, you decrease. Okay? So therefore, ventricular contraction is going to increase ventricular pressure. Ventricular relaxation is going to lower ventricular pressure. Okay? So when the ventricles contract, the AV valves are closed, right? Because we don't want blood pouring into the atria. Ever forward. Okay? The semilunar valves will open up. And the best way I can kind of describe that to you is, I know I keep saying this, but puff your cheeks out and then keep pressing. Eventually, the air is going to escape your lips. And that's what happens with the semilunar valves. Okay, because remember, valves only open in one direction. So if you keep building up the pressure in your mouth and with your cheeks, eventually the air will escape through your lips. That's what happens here, right? We keep building up that ventricular pressure. Eventually, it's going to push the semilunar valves open, and we're going to eject the blood into the pulmonary trunk and into the aorta. Okay? And then, of course, following ventricular contraction, we get relaxation. Okay? And when the ventricles relax enough, the semilunar valves will close first. Okay? They'll close first, and then eventually, when the ventricles are completely relaxed, the AV valves will open up, because the pressure in the atria will be greater than the pressure in the ventricles, and it pushes the valves open as blood is pouring into the atria and then into the ventricles. That's known as passive filling. Okay? So you do want to know this. Ventricles play a huge role, right, when we're talking about the cardiac cycle here, right? Where the blood is moving from and where it's going to, and what the valves are doing. Remember on those little pictures there, we talked about what's going on with the ventricles. Are they contracting or relaxing, right? What the valves are doing, right? And the pressure gradient. Where is there more pressure? Is there more pressure in the atria, or is there more pressure in the ventricles? Is there more pressure in the ventricles, or is there more pressure in the arterial circulation, in the pulmonary trunk or the aorta? Okay, so those are the things that you want to kind of keep in mind. All right, so at the beginning of this, and we've seen this already in lab, all right, at the beginning of the heart cycle, all four chambers are resting. Okay, they're not doing anything. Okay, so blood returns to the heart, okay, and it pours into the atria. Right, the AV valves are open, so it pours into the atria and then it passes through the atria into the ventricles. Okay, so at that point, the atrial pressure has to be greater than the ventricular pressure, because if it was the other way around, the ventricular pressure would force the AV valves closed. Okay, so basically, all right, we have our heart here. I'll draw the lame four-chamber heart. Okay, so here's the AV valves. They're open, right? Blood pours in and directly goes into the ventricles, and it starts filling. That's what's happening here. So the pressure is greater here. I'll draw a big P here and a little tiny p here. Okay, in case you weren't sure, these are the ventricles down here. These are the atria up top. That's what we're seeing. Okay, so that's at rest. So we're starting to fill the heart up. Okay, and at the same time, our semilunar valves are closed. Okay, so those valves are closed. That tells me that the pressure outside of the heart, or the arterial pressure in the aorta and in the pulmonary trunk, is greater, right, than the pressure in the ventricles. So it's going to be greater, right? More pressure here. I'll put a big P over here and a little p over here. Okay, so that's what's happening here at the beginning of the cycle. Okay, so the first event. All right, this is where we start to get the atria will start to contract. What causes that? Right here. Here y'all, SA node. SA node depolarizes. Okay, as that SA node is depolarizing, it's like throwing that rock into the water in the pond. All right, that depolarization is going to spread out. All right, and it's going to spread out across the cardiac muscle cells. So now those muscle cells will start to contract. So what happens? The blood that's in the atria gets pushed out of the atria down into the ventricles. It's that last hurrah. Get out, blood. We put it into the ventricles, okay? And that volume of blood that's now in the ventricles is called the end diastolic volume. Okay? You need to know that. EDV. Right? It's roughly about 130 milliliters, 140 milliliters. End diastolic volume. Okay? So we're not even going to talk about the atria really anymore, because guess what they're doing? They're chilling out. They're relaxing for the rest of our cardiac cycle. So they're done. Their job's done. Okay? All right. So on to the next part of the cycle, the next phase. We call that isovolumetric contraction. When you see this word iso, means to stay the same. That means that the volume of whatever we're talking about, right? In this case, it's going to be the volume of blood in the ventricles, does not change. Okay? And if that's the case, if the volume doesn't change, then that means the valves have to be closed. because blood can't escape that chamber and it can't get into the chamber. Okay? So we're going to see the semilunar valves closed, right? And we're going to see the AV valves closed here. Okay? So what's happening in regards to the conduction system, right? Check it out. The Purkinje fibers are now depolarizing. So they're going to start to cause the depolarization of the ventricular muscle cells. What follows depolarization? Let's hear it. Contraction. Yes. Yes, yes. Okay? So as these cells will start to depolarize, they're going to start to contract. And that's what we're seeing here. All right? They start to contract. All right? And so when we start to contract, that's like, again, I know I keep using this example, closing your mouth and slowly puffing out your cheeks, adding more air. You're slowly increasing the pressure inside your mouth. That's what's happening here in the heart, except a lot faster. Okay? It's going to start to build up the pressure. Okay? But as long as the valves are closed, the pressure in the ventricles is less, all right, excuse me, yeah, is less than the arterial pressure because the semilunar valves are still closed, right? But it's greater than the atrial pressure, all right, because it's closed the AV valves. All right, the next phase is, look at the name, ventricular ejection. We know exactly what happens here, okay? The heart is contracted and it's going to push blood out of the ventricles. So if it's pushing blood out of the ventricles, that means the semilunar valves have opened up. That also means the pressure in the ventricles is greater than the pressure, right, in the arterial trunk, which is the pulmonary trunk and the aorta. Okay? So that's what we see here. So the amount of blood that gets pushed out of the ventricles, and you need to know this, is known as the stroke volume. Okay? Roughly 70 milliliters. Okay? Stroke volume is the amount of blood that gets pushed out of the ventricle. You need to know this because we're going to talk about cardiac output here in a moment. Right? So you need to know this value of stroke, or what stroke volume is. So it doesn't pump all the blood out, unfortunately. It's effective, but it's not that effective to the point where it gets rid of all the blood. And any blood that's left in the ventricles, all right, after stroke volume, after the ventricle contracts, we call that the end diastolic volume. All right, that's the amount of blood that's sitting there in the ventricle. Okay, so we know end diastolic volume, that's all the blood that's in the ventricle when all the valves are closed. Now we know what stroke volume is. That's the amount of blood that leaves the ventricles. Right? And then we have our end systolic volume. That's the amount of blood left over that didn't get pumped out. Okay? Sitting there. So we can take, all right, these values and we can start to figure out, all right, I'm not going to use the mouse to type this out. All right, if you want to figure out what stroke volume is end diastolic volume, all right, minus end systolic volume. So that's what you want to find out. What stroke volume is, just subtract your end systolic volume from the end diastolic volume. Okay? Down here, this equation is showing you if you want to figure out the end systolic volume, okay, just take the EDV and subtract the stroke volume from it. There's different ways that we can do. We can figure all that out. Okay? Almost done with the cardiac event cycle. Yep. Right. So again, you want to be familiar with what these terms are. Okay, stroke volume, end systolic volume, end diastolic volume. Okay, be very familiar with all those. All right. So of course now what goes up must come down. If a muscle contracts, it has to relax. So when the ventricles start to relax, all right. Again, when we see this name for this phase, isovolumetric, all right, that's going to tell us that the volume of the blood in the ventricles will not change during this part of the cardiac cycle. Okay? So we're going to see the pressure inside the ventricles start to fall. When it becomes less than the pressure in the arterial trunks, the aorta and the pulmonary trunk, all right, the semilunar valves will close. So no blood can enter in from that way. right? At the same time, the pressure in the ventricle is still greater than the pressure in the atria. So that will keep the AV valves closed. So no blood's getting in and no blood's getting out. So hence we call that the isovolumetric relaxation, because the ventricles are relaxing. All right? So AV valves closed, semilunar valves, where are they? No, it's not up there. Semilunar valves are also closed. Okay? And at the same time, keep in mind, the pressure in the ventricles is going to be less than the pressure in the atrial vessels there. Okay, the arterial vessels. And then we're going to finish up with the last part, which is when everything's relaxed again. So we start at the beginning, all right, of the cycle in which the ventricles are relaxed, the atria are still relaxed. So that's when we get that passive filling again. Okay, so all the chambers are relaxed. All right, the semilunar valves are still closed because the pressure in the ventricles is still less than the arterial pressure. But now the ventricles have relaxed so much, the pressure has become less in the ventricles than in the atria, and so that forces the AV valves to open up. And then that blood will flow into the atria and then down here into the ventricles. That passive filling again. Okay? I'm not going to go through those pictures. But that leads me into the next part.
Can you please click through them so when I review the video, I can pause it?
Oh, okay. Yeah, good call, good call. All right. All right, this will be the phases of the cardiac. I always like to start when everything's relaxed. So that would actually be this one right here, which is phase 5 on this chart. But I always like to start with relaxation. But this is when the atria start to contract here. Okay, and then it walks you through. All right. Yep, you got it. All right, so let's jump into the importance of understanding why do we have to know the cardiac cycle? One, because it's anatomy physiology. You have to know how the heart works, okay? But two, it leads us to this concept, this ventricular balance. And this is very important that you understand that, believe it or not, even though that the systemic circulation is much larger than the pulmonary circulation, the amount, all right, because the body's obviously, you have all that tissue, right? The left side of the heart has to pump all that blood to, but the right side of the heart only has to pump it to the lungs and then back into the heart again. So it's not going to be as big. But we have to have the same amount of blood leaving the right ventricle as we do the left ventricle. We call that ventricular balance. All right. Even though the blood that's getting pumped out of the left has to go down to your toes, out to your fingertips, all right, to all these different tissues and vessels and organs. All right. Whereas the right side, it's easy. It doesn't have to go far. The lungs are right next to the heart. That seems pretty easy, all right? But the reason why, in case you were wondering, the left ventricular wall is much thicker than the right ventricular wall because it needs to be able to push all that blood out to the body and not to the close lungs there, okay? If we somehow come out of balance, okay, if the ventricles are not pumping out equal amounts of blood, all right, then we can start to get edema. That's a problem. All right, if one side of the body is pumping out, or one side of the heart is pumping out more blood than the other, you're going to get a backup. That's usually what edema is. All right, when we're talking about any type of edema that's related to the cardiovascular system. Okay, there's several causes for edema, but if it's dealing with the cardiovascular system and a pathology, therefore, it's usually because there's a backup somewhere. Congestive heart failure. Is anyone familiar with that? One of the key signs of that is you talk to a patient, besides the normal shortness of breath, tired all the time, they'll say, I've been coughing up sputum. First thing you ask, what color is the sputum? It's pink. Guess what? You're getting fluid building up in the lungs because the heart can't get that blood out of the heart, and the blood is backing up into the lungs. Okay, and they'll say it's a frothy pink. Right then and there, you're thinking congestive heart failure. Bam. That's one example of the edema. Okay, that's an imbalance there that's going on. All right, so all this to get to this concept here, cardiac output, this should look familiar to you. This is one of those equations that you are responsible for. Okay, HR stands for heart rate, SV, we already know what that means. That's stroke volume. So in order to figure out the cardiac output, you're just going to take your heart rate, all right, and multiply it by the stroke volume. So on average, our stroke volume should be about 70 milliliters. So you can figure out your own cardiac output right now while you're sitting there, not doing anything, okay? You just take your heart rate, multiply it by the stroke volume, okay, and there you go. So what is cardiac output? How much blood in 1 minute, 1 minute, how much blood is pumped by one single ventricle? Oh, we assume that the ventricles are going to be pumping out the same amount of blood, okay, in a healthy heart. Okay, so it doesn't matter if it's left or right. Okay, so whatever the stroke volume is going to be, how much, all right, that one ventricle is pumping out in a minute, right? And so we use the volume that we use is liters, okay? And we use this to determine how healthy or how effective our cardiovascular system is, okay? Our cardiac output should definitely increase during periods of exercise. And that's easy to think about this. You don't even have to, if you're just a math person, perfect. All right, an equation person, right? When I say that cardiac output increases in healthy individuals during exercise, and then you look down at this equation here, why is that? Bingo, bingo. Right, we're all sitting here, we're not doing anything really, so our heart rate should be pretty normal. But if we were all to get up and run around this floor like 5 or 6 times, and then check your heart rate, your heart's gonna be beating faster, plug that new number in, now it's no longer 75 beats a minute, now it's, let's make an easy number, 100 beats a minute. Just by plugging that in, doesn't that make sense? That would be 7 liters per minute with our new equation. There you go. See, you don't even have to think about that. You know, I mean, you don't have to remember it, you just understand it. If you understand the equation, your heart rate increases, so does your cardiac output. If you increase your stroke volume, all right, will you not increase your cardiac output? If you go from 70 milliliters to, let's say, 80 milliliters, you're going to increase your stroke volume, or your cardiac output, okay? So just let the numbers do the talking. All right, questions about that so far? Not too bad, right? It's a lot, I know, but not too bad. Okay, so now we're going to talk about what happens with resting cardiac output. Right now, all of us here, okay? Our resting cardiac output only needs, you know, to be enough to satisfy our metabolic needs for our tissues as we're sitting here. So it shouldn't be that high, right? So as we're sitting here, we're not doing anything, okay? Our cardiac output should be enough to sustain our tissues. Now, if we were to start to exercise, then obviously our cardiac output's going to increase. But now when we're dealing here, all right, with the resting cardiac output, smaller, I'm going to use animals. Has anyone here ever seen the Gremlin movie? Gremlins, the original one? There's a scene in there in which they're watching a movie, all right, and they're comparing the heart rates for a bird versus an elephant. And basically, they make this same comparison. So we'll say individuals or animals with smaller hearts will, yes, have a smaller stroke volume, so they have to beat faster. That's why a bird has a really fast, like a hummingbird, right? It's like,
And children,
yeah, absolutely. That's yeah, exactly. And that's where I was going with this. You read my mind, girl. All right, that's what happens in smaller individuals, kids. All right, they have their resting heart rate is going to be higher than ours, and that's normal for them. Okay, because one, well, their metabolic needs are going to be different for the most part too. All right, but they have to have a faster heart rate, right, in order to establish that required cardiac output that they need for the tissues. Whereas bigger individuals, like elephants, for example, have a really slow heart rate because their heart is so much bigger. So each contract, so it can contract and push out that stroke volume, right? But they don't have to do it as fast, right? And so that same comparison applies to us here, okay? Little kids, women in general, children more so, all right, compared to adults, all right, and whatnot, okay? So larger hearts, larger stroke volume, slower heart rate. So the resting heart rate in individuals that are very athletic, okay? My resting heart rate when I used to work out quite a bit was in the 40s, which was good. It was good for me, you know? Now it's like in the 60s or whatever. I'm not in shape. So, you know, point being is my heart would beat less at my resting heart rate, okay? Because my stroke volume was larger, okay? So it would beat slower. All right. So what is this, cardiac reserve? Well, guess what? When we check your cardiac output when you're at rest, and then when we check your cardiac output when you're exercising, all right, you're going to get two different numbers. And we just saw in that example that I gave you on the other page there, all right, if your heart goes up from 75 beats a minute to 100 beats a minute when you're exercising, your cardiac output will go to 7 liters instead of the 5.25 liters when it's at rest. Okay? Oops, that's supposed to be an L. All right, that's going to be per minute. All right? So the difference between these two numbers here, all right, is the cardiac reserve. So basically, what is that? That's the capacity, all right, that when we increased our cardiac output, the difference between, all right, that increase that we saw, which is what, 1.75 liters there. All right, that 1.75 liters is going to be the cardiac reserve. And that's basically how much more our cardiac output increased above the rest level there. All right, so we're going to talk about now, well, not today, all right, but we're going to talk about how, all right, our heart rate, all right, increasing and our stroke volume increasing, all right, is going to have an effect on the cardiac output. For obvious reasons, you know the equation. The cardiac output equals stroke volume times heart rate. All right, so if you increase both of those numbers, heart rate and the cardiac and the stroke volume, you're going to get an increased cardiac output. If you increase just one, you're still going to get an increased cardiac output. Okay, so those two play a huge role. All right, so we'll talk about that. Oh, which is perfect, because that leads me into variables that influence the heart rate. We're not going to talk about that today, but I'm just leading into that. Okay, so we'll stop here. All right, and if you guys have any questions, ask in lab. All right, because I have a feeling once I stop recording this, it's going to do what it normally does and crash on me. Okay, so I'm going to pause this. Oop, that's not it.